Welcome to This Week in Pulmonary. This week we're covering 8 notable papers spanning advanced chronic obstructive pulmonary disease management, diagnostic and therapeutic advances in thoracic oncology, systemic infectious risks in pulmonary medicine, and comparative interventions in sleep medicine. Let's dive in. We begin this week with a focus on advanced chronic obstructive pulmonary disease and emphysema, starting with an investigation into the impact of comorbidities on endobronchial valve therapy. This prospective registry study evaluated whether the presence of multiple comorbidities affects the safety or clinical efficacy of endobronchial valve treatment in patients with severe emphysema and lung hyperinflation. The investigators analyzed data from 202 patients who underwent the procedure between 2016 and 2023, stratifying them into those with fewer than 3 comorbidities and those with 3 or more, which accounted for 51% of the cohort. At 12 months of follow-up, both groups demonstrated significant and comparable improvements across all primary clinical metrics, including forced expiratory volume in 1 second, residual volume, 6-minute walk distance, and St. George's Respiratory Questionnaire scores. Furthermore, the rate of adverse events did not differ between the two groups, and over 3/4 of all patients reported high levels of treatment satisfaction. This evidence suggests that a high comorbidity burden should not act as a barrier to endobronchial valve evaluation or referral, as these patients derive similar clinical benefits without experiencing an increased risk of complications. Remaining with chronic obstructive pulmonary disease, a systematic review in the International Journal of Chronic Obstructive Pulmonary Disease evaluated the clinical and physiological utility of high-flow nasal cannula therapy during both acute exacerbations and stable chronic states. Drawing from 14 primary studies, including 7 randomized controlled trials and 7 observational cohorts, the review demonstrated that in acute settings, high-flow nasal cannula therapy consistently improved arterial carbon dioxide levels and reduced respiratory effort compared to conventional oxygen therapy. It also significantly lowered treatment failure rates, which dropped from 19.4% with conventional oxygen to 10% with high-flow nasal cannula. However, the therapy failed to establish non-inferiority when compared directly to non-invasive ventilation for patients with severe hypercapnic respiratory failure, resulting in higher rates of treatment failure at 25.7% versus 14.3% and higher intubation rates at 14.2% versus 5.4%. Conversely, in the domiciliary setting, long-term use of high-flow nasal cannula was associated with a reduction in annual exacerbations and a meaningful improvement in quality of life, with the St. George's Respiratory Questionnaire mean difference of -8.12. These findings indicate that while high-flow nasal cannula is a valuable tool for mild to moderate exacerbations or for patients who cannot tolerate non-invasive ventilation, it should not replace non-invasive ventilation in cases of severe hypercapnic respiratory failure, and clinicians must establish clear, predefined escalation criteria. Addressing the psychiatric comorbidities that frequently complicate chronic obstructive pulmonary disease, a nationwide cohort study. Utilizing the National Health Insurance Service, National Health Screening Cohort from South Korea, researchers tracked 5,671 adults newly diagnosed with chronic obstructive pulmonary disease over a cumulative follow-up of more than 48,000 person-years. Among these patients, 603 incident cases of depression occurred. The study revealed that patients who achieved long-term smoking cessation, defined as quitting for at least 2 years, had a significantly lower risk of developing depression compared to those who continued to smoke, with an adjusted hazard ratio of 0.66. This protective association was particularly pronounced among patients with severe chronic obstructive pulmonary disease, where long-term quitters experienced a 60% reduction in depression risk, represented by an adjusted hazard ratio of 0.40. This epidemiological evidence strongly supports the integration of aggressive, sustained smoking cessation programs into routine chronic obstructive pulmonary disease management, not only to preserve lung function, but also to mitigate the high burden of psychiatric morbidity in this population. We shift our focus now to thoracic oncology and diagnostic pulmonology, starting with a prospective cohort study published in the American Journal of Respiratory and Critical Care Medicine that compared the diagnostic yield of next-generation sequencing using concurrent endobronchial, ultrasound transbronchial needle aspiration, and liquid biopsies in patients with non-small cell lung cancer. Among 199 subjects, the diagnostic yield for detecting epidermal growth factor receptor mutations was 9.5%, with endobronchial ultrasound transbronchial needle aspiration, and 7% in blood, representing a non-significant difference of 2.5%. However, when evaluating all clinically relevant oncogenic targets, tissue sampling via endobronchial ultrasound transbronchial needle aspiration achieved a significantly higher diagnostic yield of 39.7% compared to 29.6% for liquid biopsy, yielding a significant difference of 15.1%. Using tissue pathology as the reference standard, liquid biopsy demonstrated a sensitivity of 53%, a specificity of 95%, a positive predictive value of 89%, and a negative predictive value of 74%. Crucially, 37 patients had mutations detected only in tissue, while 7 patients had mutations identified exclusively in the blood, indicating that while endobronchial ultrasound transbronchial needle aspiration remains the superior diagnostic modality, liquid biopsy serves as an important complementary tool that can identify actionable therapeutic targets that might otherwise be missed due to tissue insufficiency or tumor heterogeneity. In the therapeutic domain of thoracic oncology, the safety of administering immune checkpoint inhibitors to patients with pre-existing asthma has been a clinical concern due to the risk of immune-related pulmonary toxicities. A retrospective cohort study published in Respiratory Medicine addressed this clinical question by evaluating 340 adult cancer patients with pre-existing asthma who received at least one dose of an immune checkpoint inhibitor. Poor asthma control, defined as a composite of medication escalation, exacerbations requiring systemic corticosteroids, or asthma-related hospitalizations within 6 months of treatment, occurred in only 16.5% of the cohort. Specifically, 11.7% required medication escalation, 6.5% experienced increased corticosteroid-treated exacerbations, and 2.7% had increased asthma-related hospitalizations. While higher cumulative doses of immune checkpoint inhibitors were associated with poor control in multivariable analysis, the investigators noted this likely reflects longer treatment exposure and follow-up time rather than a direct dose-dependent toxicity. Importantly, traditional baseline clinical predictors of asthma severity or checkpoint inhibitor-related pneumonitis were not associated with worsening asthma control. These reassuring findings suggest that immune checkpoint inhibitors can be safely administered to the vast majority of cancer patients with pre-existing asthma, provided they receive standard clinical monitoring. Moving to infectious disease complications in oncology, a retrospective cohort study in respiratory medicine highlights a critical gap in the preventive care of patients with solid tumors who develop pneumocystis jirovecii pneumonia. Out of 866 patients diagnosed with proven or probable pneumocystis pneumonia within a large integrated health system, between 2017 and 2025, 190 patients or 21.9% had solid tumors. This subgroup experienced exceptionally high mortality, with 30-day and 90-day all-cause mortality rates reaching 37.9% and 48.4% respectively. Although 54.7% of these patients had documented chronic corticosteroid use that met or exceeded standard thresholds for prophylaxis, only 3.3% were actually prescribed pneumocystis prophylaxis prior to their infection. Multivariable analysis showed that metastatic disease, chronic corticosteroid use, and lymphopenia were independently associated with 30-day mortality. Furthermore, compared to other patient populations with pneumocystis pneumonia, those with solid tumors had more than double the odds of 30-day mortality and a significantly higher risk of severe disease. This study underscores an urgent need for oncologists and pulmonologists to recognize the profound risk of pneumocystis pneumonia in patients with solid tumors receiving corticosteroids, and to systematically implement guideline-recommended prophylaxis in this highly vulnerable population. Further expanding on the systemic risks associated with chronic pulmonary infections, a nationwide population-based cohort study published in Respiratory Research investigated the long-term risk of developing cancer in patients diagnosed with non-tuberculous mycobacterial pulmonary disease. Utilizing the National Health Insurance Service database of South Korea, researchers identified 21,879 patients newly diagnosed with non-tuberculous mycobacterial pulmonary disease and compared them to over 218,000 age and sex-matched control participants. After adjusting for baseline demographics and health checkup results, patients with non-tuberculous mycobacterial disease exhibited a 22% higher risk of developing any form of cancer compared to the control group, with an adjusted hazard ratio of 1.22. When analyzed by specific cancer types, the risk of developing lung cancer was more than doubled, showing an adjusted hazard ratio of 2.25. Significant risk elevations were also observed for multiple myeloma, ovarian cancer, pancreatic cancer, and liver cancer. Conversely, the risks of stomach and colorectal cancers were slightly reduced. These findings suggest that the chronic inflammatory state, or shared predisposing factors in non-tuberculous mycobacterial disease, may contribute to oncogenesis, highlighting the necessity of implementing systematic cancer surveillance and long-term monitoring, particularly for lung cancer, in patients with this chronic infection. Finally, in the field of sleep medicine, the prospective non-randomized FLOSAT study, published in the American Journal of Respiratory and Critical Care Medicine, compared the clinical effectiveness of mandibular advancement devices as a first-line treatment against continuous positive airway pressure as a second-line therapy in 94 patients with moderate to severe obstructive sleep apnea. The primary outcome was mean disease alleviation, a composite metric that integrates objective physiological efficacy with patient adherence. The mean disease alleviation was 49.9% with the mandibular advancement device and 49.1% with continuous positive airway pressure, demonstrating non-inferiority of the oral appliance. Physiologically, continuous positive airway pressure reduced the apnea-hypopnea index more robustly, bringing it down from 24.2 to 4.1 events per hour, compared to a reduction to 8.4 events per hour with the oral appliance. However, nightly adherence was significantly higher with the mandibular advancement device, averaging 6.7 hours per night compared to 5.4 hours with continuous positive airway pressure. Additionally, 51% of patients preferred the oral appliance, whereas 42% preferred continuous positive airway pressure. While these results suggest that mandibular advancement devices can achieve comparable overall disease control due to superior patient adherence, clinicians should interpret these findings cautiously, as the sequential, non-randomized design cannot rule out order or period effects, and mean disease alleviation has not yet been validated against hard, patient-important clinical outcomes. If you only have time for one paper this week, make it the prospective cohort study on concurrent endobronchial, ultrasound transbronchial needle aspiration, and liquid biopsy next-generation sequencing in non-small cell lung cancer. This study provides critical, practice-changing evidence demonstrating that while tissue biopsy remains the most reliable diagnostic standard, concurrent liquid biopsy is a highly valuable, complementary tool that identifies actionable oncogenic mutations in patients who would otherwise be missed. Here are the key takeaways from this week in pulmonary. First, endobronchial valve therapy is safe and effective in severe emphysema patients regardless of their comorbidity burden, so do not withhold referral based on comorbidities alone. Second, high-flow nasal cannula improves physiological parameters and reduces treatment failure compared to conventional oxygen in acute chronic obstructive pulmonary disease, but it is inferior to non-invasive ventilation for severe hypercapnic respiratory failure and must be used with clear escalation criteria. Third, concurrent tissue and liquid biopsy next-generation sequencing is the optimal approach for non-small cell lung cancer, as liquid biopsy successfully identifies actionable mutations in a small but clinically significant subset of patients with negative tissue biopsies. Fourth, patients with solid tumors on chronic corticosteroids are at high risk for pneumocystis jirovecii pneumonia and experience high mortality, highlighting a critical gap in prescribing appropriate prophylaxis. Fifth, non-tuberculous mycobacterial pulmonary disease is associated with a significantly elevated risk of overall cancer, particularly a more than doubled risk of lung cancer, necessitating systematic long-term surveillance. That's your roundup for this week in pulmonary. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.